Good afternoon, everyone, and welcome to the Universal Health Plan Governance Board Transition Committee this afternoon. I'm glad you're here. Isabel, will you please call a roll call? And this will also be our tech check for this afternoon.
I will in just a moment as soon as I get everybody situated. Uh, would we like to get started with who we have here today, or do we want to wait for a quorum?
Let's give it 2 more minutes and wait, and then we'll go, okay?
Sounds good.
Thanks for those of you who are here on time.
Okay, I think we can go ahead.
So once again, everyone, welcome. Good afternoon. I'm glad you're here. This is the Universal Health Plan Governance Board Transition Committee. Isabel, go ahead and call roll, please. And everyone, please check your video and audio.
Right. Judy Richardson,
I am here.
Mike Leahy,
Here.
Mary Lou Henrich,
Here.
Mickey Dirting, don't see Mickey yet. Jensina Hawkins.
Here.
Charlie Swanson. Don't see Charlie yet. Richard Gibson.
Here.
Antonio German.
Here.
Eve Gray.
Here.
Anne Lovejoy.
Here.
Paula Weldon is absent today. Jamie Osborne. Jamie, I see you, but I don't hear you. Oh, Jamie can't hear us right now, but we see her. So she is here. And that's everybody.
I will turn it over to Dr. McDonald. Do you want, and either one of us can go through the agenda. Is the next slide the agenda?
Yes,
Cool. Thanks, Mimi.
sure, you bet. Okay, so I'll take this one away. Apologies for this is Dr. Mimi McDonald, the Executive Director of the Universal Health Plan Governance Board. Thank you for all for being here. The agenda, there are no further introductions. I just forgot to take that bullet point off, so my apologies. I will be doing board updates and next, Senior Policy Advisor Lee Hastings will be going over implementation sequencing, which we hope we'll have a robust discussion about that, and then also governance and statutory gaps. I'm going to do just a few very, very brief sides on system readiness. Then we'll have member reflections and homework, things to think about for the upcoming week, 2 weeks, and then we will have our public comment. So if you want to go on to the next slide, Isabel. As long as there aren't any questions about the agenda, I will take it away. So first up, the last board meeting was held on April 16th, and a couple of announcements. One of them is that we are anticipating having board member changes. Actually, both of our board chairs for our amazing community engagement and communications committee will be eventually rolling off the board. Michelle Glass, who graciously extended her tenure on the Universal Health Plan Governance Board. She was supposed to end in January of this year, and she rolled it all the way through to September to time with the report being finalized. So we're so grateful, but she will be rotating off the board at the end of September. And then our other amazing CECC chair, Amy Fellows, her tenure is up at the end of this year. And she will be rotating off the board at that time. What that means is that there will be 2 board openings, and we're working on getting all of the information available so people can make applications. So the 2 slots that are open, however, are for people who are involved in community engagement, which is just part of the way that the board is set up. And so you'll hear more about that. We will, as I said, I won't get misty now, but boy, are we going to miss them. All right. So other things that we went over at the board meeting, talked about the basic revenue plan. A vote was not held, but it was a great opportunity for the board members to be able to dive in and really have a solid understanding about all the different tenets or portions of the revenue plan and ask questions. So it's anticipated at the next board meeting, which is on May 21st, excuse me, the next full board meeting is on May 21st. At that time that there will be more a vote on some of those issues. The plan had been to talk about the a revenue plan around reserves, but that's going to be deferred to the May 21st meeting as well. We also went over a summary of the proposals and planned out the board agenda for the next couple of months. And then lastly, the Milliman final report has been available. And once again, our consultant group from Milliman was able to be at the meeting, and board members were able to ask some questions. And Milliman called out a couple of things in the report that had not been necessarily immediately evident. So it was a great opportunity for that. And I think that's it. So I think go on to the next slide. And I'm going to turn it right over to Lee Hastings.
All right, thank you so much. So we are going to talk a little bit about implementation sequencing, hopefully narrowing down to a couple of possibilities so that next time staff can bring some more refined options and there can be a vote. And I'll just say personally, I'm super excited. I've thought a lot about this topic, so I am really, really interested to see what all of you think about this. Next slide, please. All right, so our objectives, first, we're just going to start, I just want to be really clear what we're talking about here to there. Then we're going to go into our pathway options. There are 3 that we're talking about, a little bit of a deep dive on trade-offs, and then some reflective questions. Specifically, I have a Menti poll prepared. Isabel will be sharing the link to that so that we can get some feedback to lead into your discussion. Next slide. All right, so from here to there, I know we've all seen this before, but I just want to be crystal clear. No one's trying to change what the final version of the plan is. The board has a pretty comprehensive idea of that, which is, of course, built off the previous work of the task force, where we're talking about, coverage for the entire state. So that is our endpoint, and nothing that we discuss here today alters that. That's just the finishing point, and what we're talking about are more like steps 1 and 2. Next slide. So from here, this is where we are today. We know that we currently have a highly fragmented system with respect to payers. And I would say not only payers, but just the sheer number of plans in this state is astronomical. So that is just a lot of variation, a lot of complexity. We know that approximately 47.5% of Oregon residents have primary coverage that is tied to federal financing. That's a very real constraint that we're going to talk about today and determine how we would recommend addressing that very real constraint. But knowing that the state cannot control implementation timelines for about half of the population if it is seeking to preserve federal revenue. And we know that that is one of the key principles of our financing plan, is trying to preserve and maximize federal revenue. So just understanding there's a lot of tension and there's no right or wrong answers, but we're really looking to get direction on how that, control over timeline, needs to be traded off with maintaining that federal financing. Mary Lou.
Yes, I know we were told that by the OHA representative when she did the stuff about when we could apply for new waivers, et cetera. And I happen to have asked Bruce Goldberg, who used to be the director of OHA, whether that was truly the case. And he said no. He said that we cannot, we can, if we want to change, we can change before 5 years. But they can't change on us before 5 years unless we ask for it. But it was just kind of like, oh, we really wouldn't have to wait to do a waiver application for that 5-year time. And at least when Bruce was head of the place, he said that was the case. So I just want,
I am not sure what the conversation with you, but I can tell you absolutely federal approval is required to make any change to waivers, like full
I-
stop. And that is
I-
not something that as a state we have control over. That is the very narrow constraint that I am talking about.
okay,
That's
I'm
just
just
that.
talking, okay, I was just talking about the idea of the timeline and that we could ask for changing our waiver sooner than
Yes.
a 5-year period.
Yes, it does not have to be on the, I agree with that. But it remains subject to federal approval. I am going to go through these next few slides without taking questions, just because I want there to be kind of a continuous discussion period here. So next slide. This is mostly as reference, but just to kind of back up those numbers that I gave you regarding those that have primary coverage that is tied to some level of federal financing. We see here our non-federal portion, which is about 52.5% of the state. This includes, of course, state employees, a big chunk of folks that are under the private employer-sponsored health insurance, and then, of course, smaller segments of incarcerated and uninsured. Next slide. And again, as I said, these are meant for reference. We're not going to dive into it, but more for you to look at as you're reflecting on the discussion today. These are the populations that would require some level of federal authority. Now, notably, there are some of those legal authorities are in red text because we don't actually have a pathway for them. They are smaller populations, but it is worth noting that there are some populations that as of today in current federal law, we actually have no way of incorporating. So those would really operate on a very unknown timeline. Next slide, please. So we've seen this one before, but just to emphasize, there's really a spectrum that we're choosing between here. Day one, single payer, again, single meaning as much as possible that we're able to get under the tent. And day one, what I would call universal coverage, meaning everybody has guaranteed coverage, but there might be multiple payers involved in getting that coverage. Next slide. All right, the meat of it are 3 pathways to universal coverage here. Really 3 general models, and as I said, there are decisions that have to be made within these, so we're hoping to narrow to 1, maybe 2 of these that we can explore further. These models, though, are the Big Bang, which really prioritizes full consolidation. This is kind of day one, everybody, everything. What you're really trading off here is control over the timeline. It takes a lot more time if you want to bring everybody into the tent all at once. And you are giving up a little bit of control because you are dependent on the feds to approve a lot of this stuff. Our second model here is a service phase-in. This prioritizes building a system somewhat incrementally. So it would mean partial coverage at launch, and we'll talk about what a couple examples of that are. And the third model would be a population phase-in. So this prioritizes really that coverage expansion and bringing in different segments of the market. Our key trade-off here, of course, is that fragmentation is also addressed incrementally. We can't do it all at once if we're going to do a population phase-in. So that takes longer. Next slide. All right, so the Big Bang, I don't just want to read through all of this. Hopefully you all had a chance to take a look at it. I do want to highlight some of the key risks and trade-offs with this, as I will with all of them. Again, that timeline is really driven by those federal approval processes that are outside the state control. It does have the highest implementation complexity and coordination risk. And it does carry a lot of risk with respect to just that dependency and the startup and reserve costs. Some key examples of this are, of course, the UK and Taiwan. I'll also note that Vermont's system was based on a Big Bang theory, and there is, you know, some suggestion, some evidence that that may have been a little bit of its undoing in that, you know, in the end, that financing for the entire population is part of what caused that to collapse. Next slide, please. Next is a service phase in, and this is something where we would start with, you know, one service, primary care being a potential example or set of services, and then slowly kind of ramp up to more comprehensive. So being able to cover everybody, but not everything. And of course, that is the key risk and trade-off here is that you're not offering comprehensive coverage. So if you are offering primary care to everyone, it can potentially create a conundrum when someone does need more advanced care and they don't have access to it. That's a very real limitation of this. There is also a limited ability to influence the total cost of care because you are just addressing, again, a smaller segment of what that is. And of course, the potential for confusion. Service phase-in is what Canada did when it was initially implementing its healthcare reform. So it started with hospital care and it expanded later to include physicians and then more broadly other services. And in fact, as I was doing a little bit of pre-research before this meeting, they're continuing to kind of incrementally add services. So they're the key example for a service phase-in. This is something that also Washington State is exploring. So very, very early in the process, but they are looking at the idea of what it would mean to have kind of a guaranteed primary care for all benefit. Next slide. And then our third option to consider is this population phase-in. And what this would look like is taking different market segments and moving them into a statewide universal health plan and really trying to phase it in a way that allows for the incremental increase of that population, as well as the building of those systems over time. The key risk and trade-off, of course, is that when it comes to addressing fragmentation and getting some of those, you know, big number benefits of a single payer, that's going to be incremental. That is going to take a longer amount of time. You will see some benefits, but you're not going to see, you know, an immediate transition to the kind of savings maybe that Taiwan or the UK experiences with the single payer. So you are delaying that single payer aspect. You also are delaying that integration of the government populations, which is a substantial amount. So you do have less of an initial impact overall on the market. And it does require managing those pathways during the transition, being able to help providers navigate still being in a multi-payer environment. Next slide. And based on, I know I went really quickly, but there were little profiles up in the top noting how some of these scored with respect to a couple different dimensions. And this is really just my summary of all of that. When we're looking at timeline control, the amount of federal dependency, implementation risk. I often think about, you know, when the ACA marketplaces first went live and how some states just abjectly failed. You know, there is more implementation risk the bigger your initial model is. That's just how it goes. Things like how much system leverage there is. So obviously the Big Bang performs very well with respect to getting lots of system leverage and those startup costs too, which is a very real concern. We have to raise the money for all of this. The bigger that initial program is, the more funds you need to get it started. So just looking at these comparative trade-offs, can maybe give you some sense of, you know, thinking, you know, what really matters? What does this committee feel should be prioritized? Next slide. All right, so Isabel, I don't know if you've been able to share the link with committee members, but I would like us to do a quick poll.
Yes, so that you all should have received all the committee members should have received a link via the Zoom chat in a private Zoom chat.
And if I could share my screen. Here we go. All right, can folks see this? And Charlie, I'm going to wait till the end of the poll for questions, just because I think that'll be a good time for general discussion. And I want to get people sort of first impression feedback here. All right, so can folks see?
No,
It says test, would you rather live with cold winters or hot summers?
Yeah, and then
And that's
hopefully,
what's showing on the screen.
yeah, and then hopefully other folks have that up. And if you want to weigh in, this is just our test question, just to get everyone familiar with.
How do we respond?
You should just be able to vote if you go to the link that was provided in the chat.
Oh.
Charlie, it's an individual one from Isabel. It's adjacent to everyone
Yeah,
in
yeah,
chat.
yeah. I got it. Yeah.
And this is just a fun one to get us started. Okay, I'm not actually sure how many committee members we have present, so I think 9 might be it, which tells me that everybody seems to have made it here, and there's a preference for hot summers, which yeah, I'm definitely in the summer crew, so kudos. All right, now just 5 of these questions, and these are all would you rathers. Again, there are trade-offs. Like a true would you rather, there's no ideal, but given the choice, would you rather wait to launch somewhere in the 4 to 10 year range until all major programs are integrated into a single unified system, or launch earlier using populations that the state has control over with additional populations integrated as federal pathways are secured?
I want to weigh in because I don't think that I think there's other options. I just think we should be talking about other options first.
Yeah, and I think we can absolutely talk about other options at the end of this. This is just a temperature. And if you don't feel comfortable answering, you do not need to answer a particular question. All right. And our next would you rather offer comprehensive benefits to a subset of residents, expanding to include a greater proportion over time, or offer a limited benefit such as primary care to all residents? All right, this one seems to be a pretty even split. Okay, 5 and 4. And our next one here, would you rather launch a universal health plan with a limited benefit available to all residents, expanding over time, or launch only when a comprehensive benefit can be offered to all residents? So limited for all benefits or comprehensive for all residents. Okay. Now here thinking about what we would least like to see. So least like to see universal coverage that is achieved with multiple payers remaining in the market, something that has a partial benefit at launch, or a sort of extended wait to launch. Which of those is least favorable? Even so far. Take 4 and 3. Okay. All right, and this is our final one here. If you had to prioritize what matters most to you in terms of thinking about implementation, something like primary care for all, and this is what matters most kind of as an immediate launch point. Having a basic benefit for all, having a unified single payer system for all residents, or being able to implement more quickly and have control over that timeline. Okay. Well, thank you all very much for that. And yeah, Isabel, I think we can go back to screen share and probably open that up for some discussion. I can tell you just from my really quick analysis, it seems that this committee has kind of the lowest preference for a service phase in, but it seems pretty even between a big bang and a population phase in. So Charlie.
Yeah, so to me, I mean, a big bang with preparatory changes to the system, I think is different than just the big bang and wait, or wait and then do a big bang. It's so to me, a rational other option to be considering is what sort of preparatory changes will help now, but also allow us to get to a single payer system without hurting the likelihood of that. So, and there's all sorts of things that we could change in the meantime, and just to give some options of things that could be thought about, and also would provide some testing ground for things. So the state could apply to become a Medicare Advantage insurer. So that's one thing, and so you could get practice with that kind of a work. The state could, if we did better, if we strengthened the prescription drug purchasing program, among the things that we could try would be the state offering a Medicare Part D plan, a standalone Part D plan. That could work in along with the Medicare Advantage if the state did that part of it. So there's a number of options of that sort that could be done, help people immediately, save money, and make it the path towards a eventual single payer system earlier. We could probably think of other things that can be done to help with that. So to me, that seems to not be one of those, is it a big bang, or is it a service phase in, or is it a population phase? And it's a little bit different than any of those. So I just want to put that out there as something to be thinking about.
Yep. Thank you. I think that could absolutely fit under, a refined big bang strategy. So I appreciate that. Judy?
Thanks for the exercise. I'm always uncomfortable when I'm like having to choose between options that I don't really like. And it was a challenge to think, okay, this is an interim step towards the broader goal. So I really appreciated that exercise to kind of stretch our brains. I'm going to just put out there for discussion the partial benefits. So if primary care for all was a thing, and I'm speaking as a primary care provider, it's really difficult to provide care to patients when they don't have access to other services as all. And I know that would be a temporary thing as you work towards full coverage, but boy, oh howdy, that would be frustrating.
Thank you. I think Eve was next.
So I think given our environment, one of the most urgent things that is going to be happening starting in January, but much more in the summer and fall of 27, is that our rate of individuals in Oregon who are uninsured is going to increase really rapidly. And I think if that hadn't happened, I would favor a big bang approach of just wait for everybody to be able to be covered and then cover everybody, because we have today really pretty good coverage in the state. But given, and you know, of course, we're already seeing some uninsured as a result of the changes to the marketplace tax credits. So since we are seeing the uninsured rate increase, it feels like it is really important to address that in the nearer term. And then there may be some other populations that we can roll in, whether it be state employees or you know, opt in for different businesses to opt into this plan as opposed to a plan that they're in. But I would promote an approach where we really prioritize getting everyone covered as fast as possible, focusing on the folks who are falling off of coverage. And I agree on the services. The thing that I worry about, if we offer partial services, then people are going to have to start carrying 2 insurances. And now we're introducing more insurances into the system and more complexity and the timeline that we're getting from here to there. And I feel like that's defeating some of the purpose. Thank you.
Thank you. Mike.
Why don't I pass and let others go, and then I'll make my remarks. So why don't we let Charlie and Tony go?
All right. Charlie, I think you were next.
So related to the HR1 problem, I mean, I don't think it's necessarily this committee's job to try to come up with a plan for that. I mean, Bruce Goldberg is on a committee with the governor's committee to work on that. It will be interesting to see what they come up with. I mean, maybe we need to work in with that somehow, but that's not our job to come up with that. Our job is really to do what was put forward in the bill that implemented this committee. So while I agree with Eve's notion that that's a critical thing that needs to happen, I think that is being addressed as well as it can by people who are specifically working on that and have been doing that for quite some time. So I think that it would be useful for us to find out what's going on with that and how we can work in with that. But I don't think we want to focus on that, especially not with the whatever 3 months left or whatever we have in this committee. So and I will say I have questions about how you could possibly do a service phase in, like putting in primary care for all, if it's going to still be multi-payer and you're not going to get the money from all of the federal plans to merge in so that it is one payer for that portion anyway. I'm not sure what benefit you have, what you gain with that, and it's just going to cost more money. And you're going to have another payer who is specifically insuring only primary care. And how are you know, where is the funds going to come for that? I just don't see how that could function in a useful manner with the sort of system we have. I mean, otherwise, if you can merge everybody in, it makes it more useful. But then, of course, you do have to get federal approval to merge in all of the federal money that goes to that. So I don't quite see how that works, but maybe I'm missing something here. So I'll stop there.
Thank you. Tony.
Yeah, I think the sentiments that I was going to express had largely been said through Charlie and Eve's comments. But, you know, I do think the cautionary tale of trying to devise something that has simplicity, but then we make it even worse. I'm all for a primary care trust and to try and start there, because we know that probably that will be a great investment and return on investment as far as what we put into the system we'll get back in reduction in costs. But it leaves the problem that if I see somebody in clinic, then I've seen them from primary care, and then I can't get them into the hospital, and then they're stuck with the medical debt and all the other items that has been mentioned. So I do think that a recommendation in our process is that to the legislature would be consideration for the governance board to put in that temporary, you know, commission, if you will, on implementation strategies, but a look at a review of what Taiwan did or what Canada did, and look at those past processes. And then, you know, I think we're dealing a little bit in the dark on clarity on what we should be aware of what those timelines specifically would be, of looking on dates on waivers, what would be to implement more of a universal purchaser for pharmaceuticals. I agree with Charlie, and I think that there are some clear stepping stones that we could recommend to set the stage for success. I think looking at the Medicare Advantage plan, I would support of us utilizing that as a tool that you could forego the waiver for Medicare potentially. I think looking at the New York Health Act also and what they're doing, they're considering going without waivers with that. And I think an investigation in this transition's not us, but well, it starts here, but I don't think we're gonna have enough time. And I think that that's gonna have to be set up in a recommendation to the legislature from the governance board with that. I also think that there is some considerations, the state of normalization of payment that might be coming actually into the long session upcoming next year that we could look at. There are some researchers on this to do that. And so some other pieces with it. Anyway, I'll stop there and see Mike with his comments.
Thanks, Tony. I wanted to note a couple things. First of all, I did not vote today because I really wanted to get a pulse of where we are yet forming as a group. I appreciate the slides and the work that Lee's done, but I think there's some logic issues here. And one of the logic issues is if you don't have to do Big Bang, but if you don't get at least a majority of the state involved, you can forget it about how to work out the mechanics of normalization or of moving market share and getting economy of scale. So, we've got to start to put some financial discipline into our conversations. That was my first point. My second point is that whatever you all think of the Milliman studies, that while they gave us some clues, they really didn't allow us to come up with a complete plan that's affordable in my judgment. Hence, I think what's absolutely critical is for us to figure out how we can reduce the expenses of the UHP, and there are very few scenarios that actually will lead us to something that's financially viable, including how to develop reserves and how to fund the transition plan. Okay, so that leads me to a conversation that Mary Lou and I had with Bruce earlier this week, and he made a few suggestions. He said one is you need to bring in people that have already met with our previous group, like Bill Shao, to talk about the economies of scale and not be so modest and cautious about savings. So I think as a board, we're still debating, are we ever going to bring in somebody to focus on whether or not we can get between 10 and 20% cost reductions? I hope we get to that. I personally think that while we can try to approach Big Bang, we at least conceptually need to do what I think a number of you are saying, which is we need to get more than half of the population in to begin to do things like normalization, right? So whether you choose the state employees and Medicaid and a few other things, you've got to make this thing big enough so that you have some credible administrative savings. Just because if you don't, and you don't get the taxation of other fundings, this is not viable, okay? So I think that while we can consider everything today, I'd like us to think about how do we get, I'm going to invent some figures, 2.5 million of the 4+ million Oregonians in some sort of path, and and move there? How do we normalize rates? How do we save money so that this thing is financially viable? Those are my comments.
Thank you. Eve?
Thanks. I think to your point, Mike, maybe there's a big bang for non-federally funded individuals, people who do not have federally funded insurance, and that it looks like would be just over 50% of the population. And to me, that the thing that we have to think about there is payments to providers would have to be higher in that model. And then once you roll in the government funded individuals, payments could kind of lower and normalize a little bit, because we'd have to be offsetting the underfunding from Medicaid and Medicare payers. But you know, we could at least do the big bang with what is within our control. And I push back a little on there being other work to address individuals who are uninsured, because I think the work that's happening today is really to balance the Medicaid budget and to manage what is the Medicaid plan looking like for people who are covered. But for people who are falling off of insurance, I don't know, unless someone else sees the plan for those individuals. I'm not hearing the plan as a provider at this point, and I really worry. I worry about our whole system as we start to see rates of uninsured increase. I think we will see not only individuals who are sicker, but a destabilization of the healthcare system in a number of parts of our state.
Thank you. Charlie?
I would argue that we need way more than 50 or 60% in order to see the savings that we can imagine appropriately getting with a nearly single payer system. I mean, essentially, there can be a huge amount of savings in provider offices. That, in my mind, is only going to occur if almost everybody is covered by insurance that has the same rules and the same procedures, et cetera. In part because, I mean, providers can have a small group that says, okay, we'll accept this patient and we'll defer to the state to collect the payment for us, subrogated for some reason. Kind of like if they're dealing with people from out of state that get services or something to that effect. But if it's much more than that, I don't see there's going to be administrative savings that we need. And I also don't see how you can fund hospitals with global budgets unless you have almost everybody in the system, everybody that's going to that hospital in the system. So I kind of think you need way, way more, closer to like 95% or more of the people covered with one plan to get there. So I really don't see how you can do consolidation without the federal programs. But again, I want to emphasize that the state can do some things to practice a little bit, and I've given a couple of suggestions, but I think there are other ways that the state we can make reforms that can save money, that can help with the current system. I mean, I'm just not seeing the viability of much else at this point. It seems like you need federal permission to get population in. I'm not sure what populations you can put together and what you'd gain by putting them together if you don't have the federal population in there. So I think I'm kind of missing how you would go one population to another and just increase the number of people who are covered within this plan. I don't see how that can move in that direction. And the same thing is true with the service thing. I'm not seeing how we can get there with that method. So
thank you. Judy?
Thanks. I have a question for Charlie asking for clarification, but I will say that hospitals do function under global payments and they do it in a micro in terms of bundled payments for certain disease processes. So they know how to do that and we can iterate that for sure. But my question for Charlie is when you say that savings realized by provider practices, are you implying that savings will be accrued to the health plan?
Yes, well, some of them would. The task force basically recommended that 4% of those savings in provide, or 4% of total expenditures of in provider offices would accrue to the health plan, and that the other portion of savings would accrue to the providers. And I think that if we're going to have a health plan that is that taxpayers are going to be willing to fund, that it probably needs to be more than that. That the task force data suggested that provider offices in a well-functioning single-payer plan could save 8 to 12%. And the task force decided to realize 4% of that by the plan. And then the rest was realized in provider offices or used to increase primary care or behavioral health and mental health care. And I think that that's a reasonable goal, but I think that you'll probably need to save even more than that, kind of along with the lines that Mike was suggesting, that we need to save even more if we're going to sell this to taxpayers. I think that's a useful discussion to have. And I think we need to, as Mike was pointing out, that we need to do a lot more work on what administrative savings should be able to be realized by a good single payer system, so that the plan is more reasonably sellable to taxpayers. So yeah, stop there.
Thank you. Jensina.
So I do electronic medical record implementation for a living. And although it's nowhere near to this scale, I think anybody who provides healthcare would say that an EMR implementation is pretty traumatic for all the staff involved, for all the doctors. One thing that's always beneficial, though, is that when you do the Big Bang thing, if you have a ton of the experts there on hand, if they're on the ground, and you've got your war room set up with people who are available for questions and answers right away. And so one thing that I'm actually really curious about in this is we're talking about how we implement this, whether we go Big Bang or by service line. And I've seen multi-specialty practices do things where they implement the EMR system for one service line at a time for behavioral health versus primary care, things like that. And I would say that I personally lean more towards the Big Bang because it tends to increase the teamwork overall in this together. Whereas sometimes when you have the staged implementation, usually it just takes one person who had a bad experience or a bad attitude to really sour everybody else's expectations further on down the line. But where I was going with that is that having the support staff available for everybody, usually there's people on the phone, there's people online, there's boots on the ground. So if we're doing this Big Bang, or even if we're doing a phased approach, what sort of support is being provided to the folks who are actually going to be rendering the healthcare and utilizing the new system?
Thank you. I did just want to provide one note
Mary
regarding.
Lou has her hand up.
Oh,
I can't figure out with the way my screen went after the whatever to how to get to the place I can put up. So I've just raised my real hand here.
okay. I'm sorry. I did not see that. Mary Lou.
That's okay. I have a real question. I think maybe it's part of what Charlie was alluding to. I do not know how we will have a taxation system that includes everybody paying increased taxes if everybody isn't going to be getting some benefit out of this right away. And so that's why I'm more for trying to figure out the Big Bang, because I think it will just really hard to convince people that we'll start paying increased taxes and some people are going to get something and some service lines or just whatever. That just is a concern of mine. The other one has to do with Medicaid. And, you know, Oregon has chosen the route of using intermediaries, the CCOs, to provide Medicaid. And that's our waiver. But we could change that. We could go back to like Connecticut and many other states. I talked to the state Medicaid director the other day, and she said that this is happening and being discussed across the nation, that many states are saying, you know, we tried that. It adds additional administrative cost, et cetera. And other states besides Connecticut are moving back away from managed Medicaid. And there are some savings there to the state as a whole. And it also gives us more the flexibility to pull those people into a single payer plan. So I just think that's an option that needs to be discussed and looked at a little more thoroughly.
Charlie.
So going along the lines of the potential reform in Medicaid, among the things that would allow is exploring the possibilities of getting closer to price parity or normalization of rates. I'm not sure how much flexibility there would be in raising those rates. I mean, I think fee-for-service Medicaid is limited to what fee-for-service Medicare pays for the highest rates, but I'm not positive of that. But it would allow us to explore whether or not to continue state-directed payments, which go through CCOs. So I mean, there's a lot of things that could happen with that sort of reform that would lead to something that is more easily changeable into a single payer system than where we currently are. So it's among those changes that I think could help now and lead us to make the Big Bang easier, and it would give the state more practice in administering that. It would if they do it badly, we'd say, well, maybe the state can't do that. But if they do it well, the voters could maybe have more trust that yes, the state could do this. So I mean, I think that's going to be one of the biggest problems. Is there's a lot of voters who wouldn't trust the state to be able to manage something this complex. And so that's why I'm emphasizing some of these things that can be practice steps for the state to get the experience and to know how it should be implemented when you get everybody in. I mean, so, you know, practice helps, I would say. So I'll stop there.
Mimi.
Thanks. I just wanted to ask a clarifying question, Charlie. When you're talking about the state, are you talking about the public corporation or are you talking about a state agency? Because I think we need
it could be done through OHA now, or it could be a public corporation. I mean, those would be choices that would need to be made at some point, but I could foresee it either way. Yeah.
Thanks.
Eve.
Since Bruce Goldberg's name's coming up a lot today, I heard him on Friday, and he did say that some form of kind of extensive CCO reform would be on the list of options for the governor to consider in balancing the Medicaid budget. So I think once we see the list of recommendations, that it's not going to come out until probably June, maybe end of June, there will be an opportunity to weigh in. And I mean, I think it makes sense to think about starting this with, if there's already going to be work to reform that system, would it be an option to put forward for the public corporation to get involved in that? But just that is one where there are multiple discussions happening, and I think multiple ideas about solutions to that problem. So we would want to get in on that pretty quickly if that was something we wanted to propose.
Thank you. Anne?
Yeah, I'm in favor of a population, whether partial implementation, because just in terms of selling it to the public, if everyone knows I'm in a big group and I'll get all the benefits, that and possibly other people will get theirs a little bit later, they still have confidence that they know exactly where they fit. And that's a good way to build trust.
Thank you. Jamie? I think you're muted if you're trying to speak.
Let's try that.
That sounds good.
Okay. I'm sorry, there's an echo. Is it still echoing? Yeah. Okay, I'm gonna stop.
You might need to turn the volume off your computer while you speak. Tony, I think while we're waiting for Jamie to get audio sorted.
Sure, thanks. Yeah, Jamie, jump in when you can. I really appreciate this conversation. This is a difficult, conversation to think about. And as I mentioned, I think part of my struggle with this is the absence. We're dealing with a lot of information that we don't have the answers to that go into this equation to help us lead the best pathway. But I do think that some of the standouts to this conversation with me is leading me more towards actually a big bang, but having the steps and all our ducks in a row and thinking about that. And I just, learning a little bit of what Taiwan did is it did take some process. The unfortunate part of this is it would be a bit delayed. It's not something that would happen in a year or two. But putting pieces in place to think through that, it may be something of a bulk of population that could come through, but I just struggle with the piecemeal system. And I think the politics too is a piece. Vermont, said, hey, we're going to do this in a certain sector and then we'll pay for it later and think through that. I think that's a big failure on how that's set up. And I think we should learn from that. I think some of the pieces that could lead to cost savings and understanding of what we're trying to accomplish here is some of the setup to the stages of that with bulk purchasing your pharmaceuticals, really clarifying simplicity in a system that really is just transactional. What we're trying to do is say, hey, health system delivery here and health delivery here, and just, the simplification of it, and as far as having multiple different payers with that. And it just worries me so much about us creating these different layers that we're not going to see savings. And then the public will observe that and say, I'm just going to pay more in taxes for this, but what am I really getting from it? So I don't know. I just share, I'm as our conversation progresses through this, feel more and more leaning towards that direction.
Thank you, Jamie.
All right, does it working now?
Yes.
Sweet. I've having that same instinct that it's better to go big or go home, because that's actually what the voters asked for, is they asked for universal coverage. And I feel that a staged approach may feel like a betrayal of delivering on that promise, unless it's super clear. One idea, and I don't know if anybody has any information about this or if anyone has tried it. I've heard a little bit of theoretical discussion about children that are covered by Medicaid, automatically raising the ceiling on that coverage, lowering the age requirement for Medicare, and having a staged approach where, like in 5-year increments, a group is added until it meets in the middle. But I'm concerned around the financial pieces, that we may have high utilization and less cost savings if we do it that way. I don't know if there's any model out there that might look at that or be able to tell us whether that staged approach is riskier financially or more viable.
Right. I do want to note that we're about 10 minutes over time. Chair Richardson, not sure if you'd like to continue this discussion and abbreviate some of the other topics or your preference.
Yeah, thank you. Let's have the last two people who have their hands raised ask their questions, and then we can move on to the governance and statutory gaps. And I think Mimi can make system readiness.
It can be very short.
Sounds good. All right, Richard, and then Charlie, you'll finish this off.
I like the idea of starting with the populations that the state can control, but I don't see how we pay for it. With taxing or the employer payroll tax, I don't see how that would work. They'd be paying for something that they're not getting. But I do think that on the way to a big bang, I think we need to look at all the other aspects that we could do. For example, drug purchasing, that we could do, getting and elimination of the CCOs that we could do, getting ready for the UHP. Thank you.
Charlie.
So among the other things that we might be able to do to get ready for the Big Bang is regulate the private insurers, the types of plans or the kind of things they cover or the rules they have for prior authorization. I'm not sure how much the state can control those things, but to the extent that we can make as many things the same across as wide a group of insurers as possible, it would help in provider offices now for that administrative savings. So maybe the state can say private insurers and Medicaid, you all have to follow these rules. And I don't know if that's a possibility, but it might be something to think about. So.
All right. Thank you all so much for such a rich discussion. Next slide, please. I do just want to let you know, we don't necessarily have time to continue talking, which is a shame, but I would welcome your comments via email or happy to set up time to chat with you if you have more thoughts. So please just reach out. We will return with some recommended approaches. It sounds like population and Big Bang are still under consideration. Service seems definitely out of the mix. So we'll go ahead and eliminate that, but return with some refinements there. Hopefully being able to vote on a recommended sequencing approach to present to the board next time. Next slide. All right, and now we're going to talk about some statutory gaps. Hopefully this is pretty simple. Let's continue forward. All right, so there were 3 that we identified in early April, and we're just going to touch briefly on them. Authorities of the public corporation, board composition and appointment, coordination with other coverage. And a lot of these are things that have really been inferred, but no one's made the decision. So what we're really looking for is just, does what we've kind of been assuming seem right to move forward? And if it doesn't, we'll adjust that. Next slide, please. Just a quick reminder, of course, that as we're talking about what we need in statute, it's all a balancing act of wanting to make sure that there's legitimacy, but not too much rigidity. We want to be able to save certain things for rulemaking. Next slide, please. All right, so recommended authorities of the public corporation. A lot of this, again, has really been sort of assumed, but wanted to bring it in front of folks to get kind of an actual read of, does this make sense? Are we missing anything critical? The operations committee did a lot of great work around the public corporation. So a lot of these things are in fact taken from the authorities that a standard public corporation would have. I also took a look at the different authorities that OHA has and DHS has and DCBS, and what would be appropriate for an entity that is going to be really operationalizing a health plan. So of course, rulemaking, that seems pretty central, but open to other thoughts. Staffing and delegation. So being able to staff, and then delegation just means, not having people who are authorized to make certain decisions that are below the level of the executive director, which is common when you have, appeals and grievances and that sort of system in place. Contracting, of course, and program administration, we'd want to be able to contract with providers. That would be a pretty key function. Rate setting, data collection and reporting, fund and reserve management, federal waiver authority. This is actually something we just recently learned. DCBS actually has some of this as well, but being able to engage directly with the federal government on waiver negotiations, it feels like, that's something we would probably want the public corporation to be able to do directly. Audits and compliance for participants. Again, ultimately, this thing will be operating like a health plan, one that is, hopefully more streamlined than what we have today, but still needing to ensure compliance of certain things. And then administrative orders and appeals. Charlie.
So I have a question. I'm not sure quite how this fits in with these authorities, but one of the things that seems like it might be useful somewhere in this whole system is an ombuds office. And I would say both, well, certainly for patients, but maybe for providers as well. And I'm not sure if that should be within or independent of the public corporation. So, I mean, maybe it needs to be in the public corporation, but maybe it needs to be independent. I don't quite know how that fits in, but it's something that I think we should be thinking about.
Yep. Great suggestion. Thank you. All right. Next slide, please. The next topic that we've really sort of talked around, and again, we're not voting on these today, so we'll be incorporating any feedback, but hoping to, get to a nice non-controversial set of recommendations for when we do vote on these. But the governing board of the Universal Health Plan, we've referenced many times, there will be a governing board. We haven't talked exactly what that looks like. So there is sort of a foundational question here of should this governing board be a new board or a continuation of our current Universal Health Plan governance board. As you can see, there are reasons for doing that. There are also reasons for potentially standing up a new board. The operations of the expectations, responsibilities of this new board would be pretty fundamentally different. What we're doing right now is design. What this would be doing is really operationalizing a health plan. That does potentially require different kinds of expertise, which would make sense for having a new board. There's a clean mandate and potentially greater, perceived legitimacy. However, continuing the board does provide some good ownership of the model. You have people that did help set it up, kind of starting with the early implementation. There is continuity, no need for some of that immediate relearning. So this is just something to think about as well. Charlie.
So, another sort of together option, I guess, would say is the new board could be set up, but among the requirements is that some of those members be from the old board. So there's some continuity there. So that's a possibility that provides a little bit of each, I think.
A hybrid approach, absolutely.
Yeah.
Okay. Next slide, please. Here we go. So just taking a look at different boards and their structures, and you can see on the far right our current board and how it is set up. But looking at those first three are actually the other public corporations that exist in the state of Oregon. And then the two following that, Vermont and New York, are the other two that, were proposed in similar kinds of legislation that was designed to get at universal statewide healthcare system. So we see a range of sizes. A lot of this, as kind of the next slide gets into, does have to do with sort of the function of the board. Those that tend to be really technically focused are often smaller. Those that are a lot more about managing coalitions and having really robust public engagement do tend to be larger. So functionality can play a role in that size. Appointment, we see a lot of the similar sort of, governor and state terms, often 4 to anywhere from 2 to 4 years, of course, wanting to strike that balance of having continuity with staggering being a really frequent strategy in order to make sure that there is, kind of a mix of continuity as well as fresh ideas coming in. And then, of course, a lot of these boards do have certain dedicated stakeholder seats. So, for instance, on our current board, we are required to have 4 members whose focus is on public engagement, but other ones, such as OHSU, they have, a specific seat for students and faculty and staff to make sure that they're getting a specific kind of broad representation. Next slide, please. So just thinking about that, here are just some high-level recommendations, and we're open to feedback and to revising these, so nothing is set in stone here. Again, that size and function, small tends to be those really expert, heavy technical boards, with the larger ones being more about stakeholders and public engagement. The recommendation is to go for this mid-size board. 9 is fairly standard in Oregon. 9 is what our current board is set at, and it does kind of strike a balance between those two things in terms of having the technical expertise as well as allowing for meaningful public engagement. As far as terms, shorter terms tend to create more political variability, of course, longer terms providing insulation. Our current standard is pretty typical, again, in Oregon, and I would say is probably appropriate for a future or ongoing version of this board, which is the 4-year staggered terms. As far as composition, this is where I'm really curious to get this committee's feedback. I do think that a board that is really tasked with the operations of a universal health plan might need some compositional changes, specifically really having some expertise in the financial sector, such as a health economist, having particular consumer representatives, employer representatives. Tribal representation was recommended by the Joint Task Force. So, of course, to the extent that tribal nations are interested, we would absolutely want to make sure that they have a voice too. So that is probably the biggest area where we would recommend maybe some adjustment, but those categories, would love to hear the feedback about what is potentially most useful. And then the appointment process, again, wanting to stick with that sort of high legitimacy of governor and Senate confirmation. I'll pause to see if there are any questions or comments on. Eve.
I would just say that 9 seems small to me, given the composition of a number of the CCO boards and all of the subcommittees that are necessary in order to set some of the policies, and then representation from the board on those subcommittees. 9 feels tight to me. I am more accustomed to closer to 15, which sounds like it'd be pretty unprecedented in terms of its size. But 11 would feel better than 9.
Okay, thank you. Charlie.
I'm kind of agreeing with Eve on this, in part because it seems like the expertise needed is it's substantial to operate this thing. I guess you can have a lot of that expertise within the staff, but in order to appropriately define the policies, seems like you need some of that within the board as well. So I kind of think that I think 11 makes sense as well. I had some other comment, but now I've forgotten it. Sorry, I'll stop.
But you can always email me. Tony.
Yeah, appreciate those thoughts and considerations of just the delegation of the work that we needed. I think thinking of the transition to the different scope of work, and I think I'd be interested to hear from existing board members currently on this, but I'm sure that will be at a future date. But I think financial and actuarial expert input would be a value. The other consideration, I just wonder, is this a volunteer board again, or is this paid positions to think about the body of work? And I think that that's something we really need to be clear and understanding of what this is going to take.
It's a great point. Thank you. Charlie.
And I think it needs to be paid. I'm not sure how much or in what manner, but I think it does need to be a paid board to oversee a system of this complexity. I think it needs to be. And I'm not sure what that means, paid for some minimal time per month or whatever, but yeah, I'll stop there.
Thank you. Anne?
I think I have more of a clarifying question. When I was going through the Oregon Health Plan report, there was what looked like a lot of overlap even in what they did. And if we start to look at a very a streamlined and simplified organizational design for this public corporation and a streamlined and simplified organizational design for Oregon Health Plan, I think first of all, we can get a lot of savings because it looked like there was waste there. But also, I think just in terms of clarity, the public corporation would be overseeing something that's less complex than what we have now. So just generally speaking, your recommendations are fine as long as we understand that that organizational design has to be really clear.
Great, thank you. All right, as I said, please send me any additional thoughts and feedback you have. Let's go on to the next slide. All right, so the final one, and unfortunately, we may not have time for a really robust discussion here, but again, would love any thoughts and comments, questions, concerns, etc. But how would a universal health plan coordinate with other coverage? So we have these various other ones. Those that are not highlighted are actually federal programs, which means we don't have the authority to necessarily make the decision, but we do have this very large segment of employer-sponsored insurance, particularly those ERISA plans where we cannot mandate that an employer use the universal health plan, but what we can do is establish certain rules about whether it is primary or secondary, which could influence uptake potentially, and that's really what we're wanting some feedback on. So next slide. And it's a deceptively simple choice, but I know as I researched it, I actually went back and forth. So would encourage everyone to take the time between meetings to really noodle on it. But two options. The universal health plan could be primary, or the universal health plan could be secondary. And what it basically means is who is paying first for coverage. If my employer continues to provide me with health insurance and it's an ERISA plan and the state has no authority to tell them to stop offering coverage, when I go into the doctor's office, who are they going to bill? Under option A, where the UHP is primary, this system would actually prioritize a universal health plan. This, of course, has benefits with respect to provider administration. It is simpler for them if they know that that insurance is going to be secondary. It can also potentially lead to faster voluntary alignment to a UHP because that employer-sponsored insurance doesn't become as meaningful. So maybe it just becomes supplemental to the extent that there are particular services that aren't considered to be adequately covered by a UHP. Cons, of course, potential labor resistance as they have potentially lost some negotiated benefits. Potential ERISA challenges. There are ways that this could be framed where it would not run afoul of ERISA, but that doesn't mean there wouldn't still be challenges to it. Option B would be the UHP as secondary. Under this, someone goes in and they would bill under that initial health insurance, and the UHP would essentially provide wrap coverage. So it would end up providing a lot more of the cost sharing coverage. This I know seemed initially appealing to me as it would be lower cost, especially if that employer uptake is low. I'll admit that I did sort of change my mind, as I said many times as I was doing this analysis. So some really interesting trade-offs here, and maybe we can just see if there are any comments, just a couple. Charlie.
So I have a question. I mean, is this actually under ERISA? Is it a choice that we could make either way? I mean, it looks like you're saying that UHP as primary has more potential ERISA challenge than UHP is secondary, is that correct?
Yes, so under ERISA, you cannot regulate an ERISA plan. You can, however, create standards that say if someone has UHP coverage, it needs to be billed first. And that is not regulating the ERISA plan. It has an effect on that ERISA plan, which is where those challenges could come up. But it is believed, based on the legal research that I've conducted, that that would be able to survive an ERISA challenge.
Okay. But then it would mean that we wouldn't get the benefit of them having their the state plan would not get the benefit of those the other plan paying first, so it would be more costly. So yeah, I guess it's interesting. Okay, thank you.
Yes, it gets only more complicated the more you think about it.
Yeah.
All right. So that's a good one, I think, for folks. Oh, Eve, go ahead.
I don't know that my thoughts are fully formulated on this question. I think that it brings another question, though, which is around workers' comp, auto insurance, and homeowners insurance. And it seems like those are systems where typically they would be primary, and the UHP would be secondary. If we're already building a system where other insurances would be primary, the problem is the more insurances we have, the more complex it is. We will control some of the costs if the provider only has to bill the universal health plan, and the universal health plan deals with all of the other billing for any other insurance. This is going to be much harder to operationalize if the providers expect it to kind of continue to manage all these things. But anyway, so I guess more questions for me than an answer to your question.
And before I get to all of you, I do just want to note the Operations Committee did actually discuss those issues. So the current proposal that the board has approved is that this would all bill through the UHP. So the workers' comp system would sit there, but it would kind of operate through a UHP exactly for the reasons you articulated in order to make that provider administration smoother.
Lee, I just wanted to interject a time check. We have about 8 minutes left in our meeting.
Yeah.
I'm sorry, I apologize, Chair. I'm going to ask if we can table the discussion of this just for now. I apologize, but I know that we have people here who are here specifically stayed for public comment. So I want to make sure that we have the opportunity to get to their comments. And this is certainly this conversation will continue.
Thank you, Director McDonald. Take notes, folks, for your thoughts right now. We'll definitely come back to it. Thank you.
And I believe that is it for me. So thank you all so much. Please do reach out to me with any further ideas.
And we are just going to glide right through system readiness, and I will bring it back next time. But I encourage people to take a review so we can just go through all those slides. Isabel, thank you. We'll come back with this. It's pretty quick. So like I said, I want to make sure we had time for public comment. We can go on to the what's next slide, though. I think that'll be helpful. One more. And I'll take this one on since I created this slide just so people are aware what's happening. So what's next? Well, you will get a little bit of system readiness next time. But also one of the important things we're going to talk about next at the next meeting is the IT blueprint, and we're really going to work on scoping that discussion. But then what we've been talking about, implementation sequencing, is coming back. And also administrative costs. So we will do everything that we can to get all information out to this committee as soon as possible. So it may very well be, before within the next week for any discussion materials that we have available. But again, just kind of keeping this in mind. And if people do have information, a study, something like that they would like to have shared with the group and posted as well, please send it to us and we will make sure that that happens. Okay, and we can go on to the next slide.
Thank you, Mimi. We did receive some written public comments. Please refer to the meeting materials for those. Do we have members of the public here to speak with us in person? Isabel.
Yes, we do. So as always, really appreciate members of the public taking their time to share public comment with us. You can submit public comment at any time via our website, and the deadline for written public comment is 72 hours in advance of the meeting time, and the deadline for spoken public comment, like we're about to do now, is 24 hours in advance of the meeting time. Today, we have one person here to share public comment, and Amy, whenever you're ready, you should be able to go ahead and share. You'll have about 2 minutes.
Great. My name is Amy Fellows, and I am a member of the Universal Health Plan Governance Board and co-chair of the Community Engagement and Communications Committee. I think most of you know me. I would like to propose that as you discuss board composition in the transition committee, and when the conversation comes back to the board, that there is a dedicated Universal Health Plan Governance Board seat for someone from a disability-led advocacy organization like Disability Rights Oregon or Oregon Council on Developmental Disability. This could be one of the current public engagement seats. There is a precedent for this with the System of Care Advisory Council, another governor-appointed body, and I am researching to see if there are others. When discussing a major change to our healthcare system that disabled people, some of the most vulnerable Oregonians, often have more contact with and experience systemic ableism in, it is important that they have representation at the decision-making tables. Currently, the only time disability has come up on the board is when myself or public commenters raise it. As a grandchild of Holocaust survivors, I am fully aware that disabled children and adults were the first sacrificed during the Shoah. As a parent of a disabled teenager, I am well aware of the conversations happening federally and in Oregon regarding the stripping of services that allowed disabled children and adults to live in their homes and communities. You may think my bringing up genocide is dramatic, but it is not when you consider we just closed Fairview here in Oregon in 2000. 26 years ago, where intellectually and developmentally disabled children and adults were warehoused in an abusive setting, and our federal administration is indicating we should go back to institutionalization of mentally ill and disabled people while decreasing access to home and community supports. As the board discusses what services look like for people currently on Medicaid and long-term services and supports, it is important that there is a committed disability voice on the board. There will be 2 Universal Health Plan Governance Board public engagement seats opening this fall and winter, and I would like to propose that we dedicate one of these seats for a disability-led advocacy organization, and that we put in our report due to the legislators in September the recommendation that all future iterations of the board have this dedicated seat as well. Also, listening to this meeting where you began grappling with Big Bang versus phase, I just want to caution us from setting up or going back to a 2-tiered system for people on Medicaid where providers do not want to see them because of being paid less. Thank you.
Thank you, Amy, for providing your oral written comments. I'm wondering if you would be willing to also submit
I will.
those written. Thank you very much for the record. Perfect.
Thank you.
All right, everyone, thank you so much for your time this afternoon and your dedication to this work. And also, I will thank you for your work between meetings, because watch your emails. We'll be reviewing board materials and committee materials prior to our next meeting. So much of our thinking and work happens between meetings, and so I appreciate your time. Anything else for the good of the order? And with that, we'll end on time. Thank you all. We're adjourned.